Aldosterone plays a central role in blood pressure regulation, promoting sodium retention, vascular stiffness, and adverse cardiac and renal remodeling. In patients with arterial hypertension, especially those with resistant forms, targeting aldosterone is an established therapeutic strategy. Traditionally, this has been achieved with mineralocorticoid receptor antagonists, MRAs, such as spironolactone, eplerenone, and more recently, finerenone. The emergence of baxdrostat, an aldosterone synthase inhibitor, raises important questions about where each approach fits in practice. MRAs remain the cornerstone therapy in specific situations. Resistant hypertension, spironolactone has strong evidence, Pathway 2 trial, as the most effective fourth-line agent in patients uncontrolled on triple therapy. Primary aldosteronism. MRAs are preferred when surgery is not an option or as a bridge to definitive treatment. Heart failure with reduced ejection fraction, HFrEF. Both spironolactone and eplerenone improve survival and reduce hospitalization risk. Chronic kidney disease, CKD, with proteinuria, finerenone with higher receptor selectivity, improves renal and cardiovascular outcomes while limiting hyperkalemia compared to spironolactone. In these contexts, receptor blockade directly mitigates aldosterone-driven end-organ damage, and the clinical trial evidence base is extensive. Baxdrostat inhibits aldosterone synthase, CYP11B2, reducing aldosterone production at the source. This mechanism may be advantageous in situations where MRAs are limited. Patients with recurrent or severe hyperkalemia on MRAs. By reducing aldosterone synthesis rather than blocking the receptor, baxdrostat may allow natriuresis and BP control with a lower risk of potassium accumulation. Spironolactone intolerance. Patients who develop gynecomastia, menstrual irregularities, or other hormonal side effects may benefit from baxdrostat, which avoids receptor cross-reactivity. CKD patients at risk of volume overload. By lowering aldosterone directly, baxdrostat could provide more predictable volume and BP control with less neurohormonal compensation. Persistent hypertension despite MRA use. In individuals with resistant hypertension who remain uncontrolled despite spironolactone eplerenone, switching to or adding baxdrostat may provide incremental benefit. Continue MRAs when they are well-tolerated, effective, and safe in terms of potassium and renal function. Their benefits in resistant hypertension and heart failure are well proven. Switch to baxdrostat when MRAs are contraindicated or poorly tolerated or when patients experience recurrent hyperkalemia or endocrine side effects. Future role. As ongoing trials clarify long-term efficacy and safety, baxdrostat may shift from being a second-line option to a front-line alternative in selected high-risk patients. MRAs remain the backbone of aldosterone-targeting therapy in resistant hypertension and cardiorenal disease. Baxdrostat represents an important advance, particularly for patients who cannot tolerate MRAs or in whom safety concerns limit their use. For now, MRAs should remain first-line, with baxdrostat considered when receptor antagonism is not feasible or insufficient.